I'm Joseph Harris. I'm the director of the Global Health Politics Workshop. We're delighted to be here today to present our sixth in our first annual series of the Global Health Politics Workshop. And today we have Adia Benton, Associate Professor of Anthropology, who has written widely on a number of global health topics, including HIV/AIDS, her amazing book, HIV/AIDS Exceptionalism. If you haven't read it, please go out and buy it. It's amazing. Also COVID, also Ebola, subject of her current book, Global Surgery, and as we learned, sports as well. And so lots of interesting topics Adia has worked on. So without further ado, I'm going to invite Adia to come into the screen, and she'll give a talk for about 40 minutes or so, 45 minutes, and then we'll have Q&A.
So thank you for this opportunity. It's essentially an opportunity. This is the first time that I've, I think, had to really deal with this. I'm not even sure if this is in my book, but part of it is, but it was an argument that I was trying to flesh out a few years ago when I was trying to think, when I was writing about militarization and policing within public health, but I was also trying to think about it as certain COVID interventions were happening. So what did it mean for this reckoning with police violence, the rise of police abolitionism, prison abolitionism, and all of those things in relation to thinking about public health? That may not make any sense right now, but it's hopefully going to make more sense once I actually start to kind of get into this case. So I'm going to read a bit about from the book and from my random thoughts about this War is Not a Metaphor, Police Power and Public Health in the Pandemic Era. And it begins in Freetown, which is in Sierra Leone in West Africa. And before 7 o'clock each morning in July 2015, including on the weekends, an American epidemiologist on a 6-week assignment for the CDC in Freetown leaves the Radisson Blu Hotel to head to the British Council, where the District Emergency Response Center is located. So from there, she heads out with her team, joining many others from the World Health Organization, MSF, and other NGOs in Magazine Wharf to investigate a troubling new cluster of Ebola infections. A typical team consists of social mobilizers, an epidemiologist, a community monitor, a contact tracer, and Ebola survivors. Members of the team move from house to house seeking what they call suspected cases and their close contacts, often not returning to their own places of residence until 7 p.m. in the evening. They enter their assigned areas of the neighborhood equipped with a list of names and addresses, knock on doors, check their household lists against addresses and known occupants of houses. They inquire of the whereabouts of house residents, pursue their leads, track down their suspects, and locate potential ones. Later, the same epidemiologist would say about those daily visits, Magazine Wharf has homes that are so close to each other, and this was a disease we're trying to avoid touch and contact, and you often had to squeeze by people. We're like, what do we do? And then the homes, you can't invade someone's space when they say this person is not home. You have to verify that there's no one hiding in the room. But how do you do that diplomatically? It struck me as odd that a year into an epidemic, a pandemic, Ebola pandemic, which by April and May of 2015, Ebola had infected more than 25,000 people and killed a third of those infected in Sierra Leone, Guinea, and Liberia. The epidemiologist and other members of the Sierra Leonean government surveillance teams felt the sick people were hiding or being harbored by Magazine residents, or they needed to verify that such fugitives did not exist. The quality of care for Ebola patients at that juncture had been expanded and vastly improved. Health education and outreach had focused on showing that early diagnosis and treatment offered Ebola patients the best chances of survival. And when this new cluster of infections emerged in Magazine Wharf, nearly 21 days had passed without any new cases in the country. Sierra Leone had been one incubation period away from declaring an end to Ebola. But as had been the case for Ebola between March 2014 and June 2016 in West Africa, cases resurfaced in unexpected places. and often among those experiencing other forms of deprivation and with respect to water, food, sanitation, reliable housing, and stable work. Active case finding and contact tracing became important methods for field epidemiologists and community health workers to make sense of ongoing disease transmission in such areas and to stop it at its source. And I'm quoting Ban Ki-moon and Barack Obama. So contact tracing efforts continue to arouse suspicion if we are to take epidemiologists and others' accounts of Magazine Wharf as any indication of what was indeed happening at the time. The other option might be to assume that field epidemiologists, field staff in general, were themselves entering communities with their own trust issues, suspicions, and paranoid readings of area residents' beliefs, behaviors, and motivations with respect to Ebola. So hold on to that thought, because I'm going to Minneapolis, May 30th, 2020. 5 days after Minneapolis police officer Derek Chauvin murdered George Floyd, and a day after Chauvin was arrested and charged with third-degree murder and manslaughter, Minnesota Governor Tim Walz held a press conference. He fielded questions from the local news media as an American Sign Language interpreter, animated and translated his bureaucratic speak. A question from the audience. Minnesota Public Radio's Ewan Kerr wants to know how the state is handling protests against police violence and counter protests by white supremacist and white nationalist groups. He asked, who are those people and what's happening now in terms of you going after them? Walz gestured toward John Harrington, Minnesota's public safety commissioner, who stepped up to the podium. And he said, as we've begun making arrests, we have begun analyzing the data of who we've arrested and begun doing what is almost very similar to our COVID. It's contact tracing. Who are they associated with? What platforms are they advocating for? We've checked to see, are they part of a criminal organization? And if so, what is that organization? And how are they organized? Now, that Harrington positively compared his investigative approach to COVID contact tracing was notable, but not everyone was happy with Harrington's analogy. Caitlin Rivers, who's pictured here, a disease modeler actually, whose Ebola research has been supported by the US Department of Defense. And she criticized Harrington's remark on social media. She said, this is not contact tracing. What is described in the video is police work. To see the two linked jeopardizes the credibility of public health, which needs community trust to work effectively. I will think about whether I should actually be showing her original tweet, but I had a response, which was that police methods and so-called shoe leather epidemiology bear more than a resemblance to each other. So when Harrington compared police work and contact tracing, he perhaps inadvertently revealed some of the structural homology between public health and policing or law enforcement that might otherwise go unremarked upon. Most obviously, the police commissioner had outlined an investigator strategy in which he and his staff engage in data collection, gathering the names and searching their databases for previous encounters with law enforcement agencies, hypothesis testing, determining whether the individuals identified are associated with formal organizations known to engage in criminal activities. In other words, is there a pattern or style that might be discerned by looking them in aggregate? And then inductive reasoning to generate a qualitative accounting for the methods of organization among criminals, or groups of people whose activities have been deemed criminal, people whose activities have been criminalized. So Rivers' enthusiastic defense of public health from its ready association with police work elides the fact that policing and public health have long been linked, not just in this police official's description of his investigation, but in the administrative, sociological, and ideological foundations of policing and public health practices. Public health, as many have argued, is a domain of police power. And I'm thinking specifically about Mark Neocleos and Mike Brogdon. And they say that the processes and activities of fabricating and maintaining social order in service of capitalist accumulation, extraction, they talk about wage labor and the protection of private property. And relatedly, police and prison abolitionists writing about the problems with disease surveillance technology, like activist Sarah Hamid, have noted that medical models for disease management and criminalization share a twin core. Distinguishing one from the other isn't just unsound, it's negligent. Techniques and technologies in one domain inform the other. So the priority in this paper has been to think with and against Rivers's and others' insistence that public health and police work are distinct from each other in pandemic response. Reading oral historical and ethnographic accounts of public health response to the Ebola pandemic in West Africa, largely taking place in poor marginalized communities in Freetown, I ask if public health and police work have been or ever can be productively uncoupled when they share a structural and ideological homology. It's even more difficult to conceive of their separation when the impulses and motivations of both have been oriented toward the fabrication and maintenance of order and containment, and sometimes punishment, rather than the pursuit of justice and care. But I'd like to try for a second. So for me, this will also entail examining the relations of trust in and of public health, of its interventions, of its agents, that apparently prompted Rivers to comment. It's now quite common within the public health set, and I would include the epidemiologist like her among them, though I think she might not call herself, I think she calls herself a modeler. Those might be different, I don't know. But she would, to argue that they argue that community trust or community engagement, through which community trust is allegedly pursued and engendered, is necessary to introduce potentially unpopular behavioral or individual interventions. And it's also necessary to help ensure compliance with those interventions. So in these pronouncements, it's also quite common to imagine that trust is something to be secured by public health authorities from the community, and it is a one-off pursuit in which the desired outcome, widespread acceptance or compliance with a specific health intervention, justifies the negotiation of trust. So I've been going back and forth on this. I'm like, what am I talking about? Because it's hard to not talk yourself in circles about the question of trust. But if trust is really what's at stake here, and I'm not sure that it is, then it would behoove us to think through its relational nature, its eventfulness, that's too easily elided or effaced when formulated as a simple transaction. So I got it from you, you give me your compliance. Community trust specifically has been trumpeted as the cornerstone of any successful epidemic response, but it presumes an unequal bilateral arrangement in which trust can be won and secured. But we also know that it can be squandered, lost, withdrawn, and immaterial. It's worth asking, it seems, whether members of the public health community or public health profession trust the people they encounter among the populations under investigation. Whom do they trust? Under what circumstances? And to what extent do those enactments of trust matter for how they engage with the task at hand, contact tracing? How much can they trust the residents of Magazine Wharf cannot be very far from their minds as they negotiate access and push and push and push. These are words that an epidemiologist used to describe her engagement in the field, to find out what is really happening behind the doors of someone's home once the neighborhood has been deemed a hotspot. That is, a community, a collective, however defined by the public health entity in question, is a group from which trust must be secured with the aim of their uptake of, and I'll say this for the third time, of a specific public health intervention. So the cases I explore here, I discuss and examine what I think of as the three functional relationships between policing and public health. And the first one, which I sort of began to sketch out, is that of public health as a functional differentiation of police power. And that's, again, the neo-Cleus sort of school of thinking, which is sort of premised on the fact that policing is much more than the police, about the police, just as war is much more than about the military, and that police power is first and foremost a weapon of the state. And so over time, over I guess a couple of centuries actually, and if you look at his writing, which spans those centuries over across Europe, a lot of the functions of that had been allocated to the police got differentiated across different state agencies and state bureaucracies. That it's a very interesting. That's from his book Critique of Police Power. I think it had a different name, and so I'm trying to remember what it is. So the second I guess functional relationship that I'm addressing is the criminalization of behaviors perceived to pose a threat to public health, and its relationship to the slippery conceptualization of trust, underlying public health ideas about communities and their non-compliance with public health mandates. So why is it that we hear of community trust as if it's to be secured as a unidirectional one-time affair? Here it's worth considering too, that people also experience these public health practices as policing. And the third of this sort of three functional relationships relates to the formal deployment of police officers in service of public health goals and as agents of public health interventions. So very literal, like the police show up. So the first, idea one. Historians and sociologists of medicine and public health have shown the links among policing and public health quite clearly. And from their description of the emergence of medical police in the 18th century Germany to the 19th century founding of the London Metropolitan Police. And I can say with some degree of, I guess, certainty, I watched a lot of British police procedurals over the past 3 years. So I'm very, like, I understand London Met in a very intimate way. No, I'm just kidding. So, and in those cases, we're talking about urban hygiene, contagion, policing forming the basis for linking social status and health conditions. So as sociologist Patrick Carroll writes about 19th century England, the public's unease with the idea of medical police. And that's also the name of a show on Comedy Central. It's actually funny. They're like, we're doctors, we're also police. And they do investigate outbreaks. So it's actually kind of amusing. And so they were uneasy with the idea of medical police, in which greater government surveillance, investigation, information gathering, intervention, and enforcement in the name of national health gave way to the idiom of public health in partnership with public hygiene and preventative medicine. So Carroll continues, in the end, public health hygiene won the day and became the master designation for all the practices first articulated as constitute the domain of police. And Foucault, in his own account of the birth of social medicine, was clear that questions of health and hygiene relate as much to the police as the field of medicine. So I love Foucault. I'm going to do this. I'm going to just put this up here. This is from the CDC Museum, and I write about this in another chapter of the book, but this is actually the chart from the magazine Wharf cluster that I began with. And it sort of tracks and traces all the suspects, so to speak, in the relationships between them. And I usually do like a very long-winded talk about just this artifact, because if you kind of follow it, there's a larger story about the labor used to produce it, the story of how it comes to be in the museum in the first place, and what it ultimately represents for the people who not only did the work in making the object, but made the object a central feature of this 21 panel exhibit. I also usually stick these in there because, you know, like I said, if you watch enough of these shows, you know that a murder wall is necessary, right? You can't, like, I had so many pictures of them that I actually saw a show of, like, maybe last year that didn't have a murder wall, and it freaked me out. Actually, she had one, but she had it, you could only see the back of the whiteboard, and they would show her looking with her friend, and it was like, but they're never meant to be seen, right? They're actually never meant to be seen by anyone except for the people who are involved in the case. Here's another one, my favorite. So this is, when I say ideological, I'm also talking about these like very material, interesting things. But anyway, the key institutions of war power and police power have been entwined since their inception. And, you know, again, Nucleus and others have written about the police discourse replete with language of ideas of warfare. If police power is at war, he asks, what is it fighting about, and who exactly is it fighting? He also interestingly reads Daryl Gates. I don't know if people remember who Daryl Gates is. He was the police chief of the LAPD during the Rodney King, and pretty much, I think, like every bad sort of racist thing that happened under the LAPD. But, you know, he wrote, I think this was in his memoir. He says, identifying the enemy makes us feel very uncomfortable. Why? Because the enemy happens to be a great many of us. Claims such as this reveal that police wars interpolate citizen subjects as objects of threat, as enemies or potential enemies, and that it therefore makes perfect sense that in those moments where the threat appears most explicit, all paraphernalia of state violence can be used, from tear gas to water cannon, from batons to guns. They reveal not only that police power is always already at war, but it is also that it is a war with the enemy within. And usually when I talk about this, or in previous iterations of this, there was a moment when Donald Trump kept drawing boundaries around the place that needed to be quarantined from the rest of the US. So he started with New York, and then it sort of became New Jersey and Connecticut. And then, it sort of expanded as he started to talk about this. But I also would show, and I apologize for just talking you through pictures that I don't have. But I feel like I'm not sure I want to continue to use them, of clashes between the police and the military in Monrovia, Liberia. So many of you know or might remember that one teenager died as a result of his wounds. And that also happened to be the week, so that was early August 2014. So it was the first Black Lives Matter that came out of other murders by the police. And so this is sort of a continuing cycle. And so when I show a video of early days in Sierra Leone to students, they see also clashes between the police, the military, and local people. Often people who've had a loved one taken from their home, or loved ones dying in the hospital without any notice about those deaths. So idea 2, criminalization. Within hours of the Minneapolis press conference, Julie Barkey, a spokesperson for the Minnesota Department of Health, told Recode, a tech industry news source, he used the term contact tracing as a metaphor. Just as we at the MDH have used the term disease investigators to describe our epidemiology processes, they used a public health term. And of course, most of you have heard of the Epidemic Intelligence Service. That's like the elite detective force at the CDC. I'm not going to. So I also used to show their logo. In fact, I think it's probably on a hidden slide here, but it's a logo of the earth with the shoe on it, like a shoe print, like the gum shoe from, yeah. So it looks like there's a footprint on the earth. And I go into a bit more about the training practices and stuff in the book, but this is one of the, I'd like to kind of read this bit from a memoir that I happened to read while I was working on this book, from Joe McCormick, who investigated the Lassa fever outbreaks in Sierra Leone in 1976, as well as the first outbreaks of Ebola in Sudan and Zaire in 1976. And just as a way of like, this is just like trivia, but Joe McCormick got from Sierra Leone to Sudan and Zaire in 1976. I'm saying this because anyone who's actually been to Africa knows that you cannot get from Sierra Leone to Sudan and Zaire very easily. And I think it was actually easier for him in 1976 than it is now. But anyway, he wrote in his recent memoir, an outbreak investigation is very much like the investigation of a crime. It consists of detective work, following hunches, carefully collecting evidence. In epidemiology, however, the criminal is the bug. Find the bug and then find out how it got to its human host. The bug's motive? Making a lot more bugs, I guess. But it's not just bugs you're dealing with. You have to deal with people, especially the victims. It requires some effort to explain to them what you're doing and then to convince them to cooperate. Now, every time I read this, I always want to remind people, like, people aren't just hosts, right? The bugs to which McCormick refers, they live in bodies. So any intervention to hunt the bug, to get to the criminal, also requires getting to the person who is hosting, harboring, perhaps, the criminal. Now, this sounds like semantics, but it's not. And it's one of those things that we kind of kept coming back to with COVID, which is you're not fighting the virus, it's living in people. So any kind of attack, any war on the virus is a war on bodies, but also a space, the space between which bodies are transmitting so what becomes the object of intervention is not just the individuals, the behaviors, but also the spaces between the air they share. So public health methods of quarantine and contact tracing often move in concert with police work, and these methods are often experienced as indistinguishable from policing, which is the thing I was saying before. So sometime in 2018, in a little restaurant in rural Ohio, I had dinner with an acquaintance, and I'm just going to call her LN. And I don't think she's here, but she knows who she is. A hemorrhagic fever expert who'd been living and working in Kinema, Sierra Leone off and on for years. She recounted how she was especially traumatized by the relentless work, death, and suffering in those early months of the outbreak. Her colleagues were dying and scared, and she was trying to manage samples and data, warding off the data vultures who came to write papers about the genomic kin relations between viruses. A contact tracing effort, she says, it was like a police interrogation. As she described the feeling of being questioned, I imagined the cement blocked room, a suspect seated across from an investigator again, watching too many TV shows. Where have you been? Who are you with? When were you with them? What did they touch? So if you're looking at the whiteboard, you actually see all of those relations mapped out. Pushing and pushing, not getting information. Something is unresolved. Who is trusting whom? So an Ebola survivor that I met during a visit to southeastern Sierra Leone in 2018, I'll call him Mo, tells me about his work as the leader of the Survivors Association, one of several such organizations that were established in the aftermath of the Ebola outbreak in each of the country's districts. The associations are a way for survivors and the organizations that used to support them, I had to add used to because the money ran out, to advocate for the rights and continued support for people who suffered an Ebola infection and lived. So many of you are probably aware that if you have lived or you've survived an Ebola infection, you often have longer term symptoms. Sometimes you have hearing loss, infertility, erectile dysfunction, eye problems, blindness, mental illness. Sound familiar? So people were kind of focused on the survivors, but less is said about the people who lost their family members to the disease. It's an opportunity for them to come together under a common cause. Sometimes that cause is better health, better access to healthcare for post-Ebola syndrome. Sometimes it's better access to healthcare for everyone. But it's also a kind of club whose members speculate on and attempt to reap benefits from a biological affiliation, an immunological membership. Another survivor, let's call her Fanta, interrupts Mo to tell me that after he had been placed in the Ebola holding center to await his test results, Mo absconded to another town to escape the terror of the holding center. I thought she was trying to tell me that Mo wasn't a perfect survivor, and maybe that was okay, and perhaps it was also funny. But a survivor doesn't simply become a survivor by virtue of having survived Ebola, but by having embraced it as an identity wholesale, which is something I talk about in my AIDS book. So I laughed and then Mo laughed, but he seemed really nervous, like really embarrassed because he hesitated. He looked at me and he kind of cocked his head to the side and he said, "You have to understand what they were saying about what went on in the holding center." He held his phone and gestured towards me with it. I was getting WhatsApp messages all the time. And I knew what they were saying in those text messages. If you didn't have Ebola when you entered the holding center, you contracted it there. There were people inside harvesting organs and body parts for sale, was another thing that I heard. There were scientists experimenting on poor Black people to see if the drugs they'd made for white people worked. The holding centers and the early iterations of Ebola treatment centers were places where people died undignified, excruciating deaths. In those places, temporary residents also saw their compatriots die. Some saw their loved ones enter the center never to return, their bodies burned or buried in unmarked graves. One could not know for sure. A surveillance expert from the government of Sierra Leone recalled, it was tough at that time. We started collecting samples. We started having cases escaping from Kinema because at that time, I think there was a problem with security. The whole structure was not too. So you had patients escaping from treatment coming to Freetown. He laughs. We had to be informed. There was a time when one of them was on television, so I had to go and locate the house, take him back to Kinema. At that time, in fact, there was BBC coverage there. I took him back. I said, "I brought your guy." So they took him. Then finally, we had our case in Freetown. It was from Kisi Road. The guy was from Kinema, and he came and he was hidden in one of the clinics. They tried to deny, but we probed and we probed. We got him. We took him to the holding center. At the holding center, there was also a problem in accepting him because they were running out of space. And they said, if we say we're going to accept everybody you bring here, it's going to be a problem. We said, please, this guy, let him be. So he was placed in holding, a sample was collected, tested, it turned out positive. That was the first case for the Western area, and then the problem started. But Mo survived and was one of the earliest of Ebola patients to have done so. I also heard in his story, in the story that Fanta felt compelled to interject into his retelling of it, that those who failed to comply, those who refused to stay in these sites that inspired terror and fear among its temporary residents were treated as fugitives. Fugitivity has its own carceral logics. Fugitives are hunted, they are tracked, they are brought back to face the consequences of their refusal. And Mo survived this too. And here are some, these are just like a few headlines. These are not even like all of them. This is the first one, which I don't think you can see very well, was a BBC report from July 27th, 2014. It says a Sierra Leone woman who fled hospital after testing positive has died after turning herself in. This other one from the US Embassy, they put out an all points bulletin for an infected woman who had broken out of a hospital. And then this Liberia Ebola manhunt, biker likely carrying virus on the run. So idea 3, which focuses on the actual use of the police. So far I've just been talking about the sort of what I call the structural homology. Now I've been talking about the language and the criminalization of the behavior. One thing I didn't mention was there was a $200 fine for anyone who was, so they revised these public health ordinances that had been written in the, I want to say they'd last been updated in 1960 something. And they updated it to reflect the Ebola pandemic, and they would levy a $200 fine for anyone seen to be harboring Ebola fugitive, so to speak. And so people were actually using that as an excuse to get a way to get rid of their neighbors, to settle disputes, and calling 117 and saying, hey, so I think that, you know, and so, so the one thing, I'm just sort of setting this up to say, and actually there's a really great anthropologist, Jonah Lipton, who's, I think his book is going to come out maybe next year, that actually talks a little bit about what it was like to deal with burials and quarantine. He was not there to study Ebola, he was there to work with young men, and this was what he was sort of dealing with. He actually wrote a really great paper about burial practices and what happened during Ebola, if anyone's interested. But anyway, so back to idea 3, which is this question of the actual police. So the same surveillance expert person that I talked about before from the Sierra Leonean government was asked in an oral history interview, were there police officers involved? And he said, yes, there were always police officers involved. And they were part of this quarantine. So they would actually be sort of stationed outside of houses and in front of mosques and all of these things. But whether they had any authority to do anything, you know, it depends on the resources available to them, which were not always great. So he says, there are always police officers involved. We would have people sneaking into the quarantine home just to get food. So the role of the police officers was to prevent anybody from going in or out of the quarantine. And they were there always, 24/7. Some of them also got infected that were quarantined, but it's like that. The cases started to drop. We were having a few clusters, more especially in the slum areas. There was a time when we thought, hey, this thing is under control. And then there was an explosion in one of the slums, Moa Wharf, which is actually next to Magazine Wharf. And then we had to go in there again, and then to Magazine Wharf. The wharf areas were areas that were giving us problems because we were having cases from Port Loco. They would travel by sea, and it was shorter by sea, by boat to the Western area, and they would come to settle. And so, in fact, so they were basically kind of pushing the northern region. So these people, should I go back to the map? Do people want to see the map? Yeah. Because it sounds ridiculous until you see. So basically, people are just sort of, you see where Port Loco is? So rather than traveling on the road, they would just go on the sea and get there because it's faster. And then there are people who were sort of a little bit Oh, I was showing you where her hotel was, very far. So people are traveling along this route on Destruction Bay, across Destruction Bay. And White Man's Bay, which is a great name for so that's sort of, this is the peninsula here, that little piece that's getting. So they had sort of come to, so part of their push, northern push, was going sort of this whole northern district, but there were a lot of cases in McKinney and Port Logo. And in fact, that's where, I think it's where Partners in Health set up their health facilities. Port Logo for sure. And so they would, so basically when they started trying to cut off the magazine wharf cases, they were starting from this Port Loco possession. So then he says there was a considerable drop in the cases along the slums. We have about 22 slums, and then right there through the country, some 49 slums around the Riverine area. Then we had to manage that. So that's, he continued, when there's a confirmed case, like in the case of Moa Wharf, we had to go there full force, physically. Us, CDCs, MSFs, WHOs, everybody. We diverted our attention there. That was how we were operating to see. It was like when we have a case, we go there, we try to meet it. Everybody was there, community monitors, contact tracings. We go around after the case had been proven positive. Anybody coming up with any sign should be tested, taken to the holding center and get tested. So as the epidemiologist is struggling to map all the connections among infections and by extension relations and narratives of blame, she wonders aloud, and this is the epidemiologist from the beginning. She says, epidemiologists always say this when there's a missing link and you're pushing and you're pushing and you're pushing and you're not getting information. But you know that there's something there that is unresolved. Pushing and pushing and pushing, you're not getting information. So I just sort of, that for some reason that one continues to resonate with me, because she's sort of looking at that chart. Actually, it's the Magazine Wharf chart that she's referring to, looking at that chart and trying to figure out, because there are actually a few, I'll show you this chart again. See, I wasn't planning to talk about this chart, but I live. So there are actually a few people for whom there is no obvious link. So we have these, that one that says related to Magazine Wharf cluster MWC on the left-hand side, but all the dotted line there, this person US M40 is one that who they can't really figure out what the connection is. It's sort of like British police procedure, right? What is the connection? What's happening? I know, I'm dramatizing it. But it's one of the things that I'm still trying to work through, which is like, what are these idioms of policing that sort of, what the pandemic procedural that they're writing for themselves. The outbreak narrative, as Priscilla Wald describes it in her work. So just to get back, you know what? Yes, I'm close to the end. I did it. So within hours of her plea to dissociate policing and public health in official statements, and I used to have this tweet, the influential epidemiological modeler that I started with softened her criticism of John Harrington, Minnesota's public safety commissioner. She wrote, I understand it's an analogy, and I'm sure this official had a very long day. But I really don't want public health and police action to get crossed in people's minds. Community trust is paramount. And I kind of want to end with this statement that I was, saw when I was reading Neocleus again, where he says, where he's sort of re-updating his argument in the book. And he says, if you're looking for solutions in this book, don't bother. I'm just a grumpy Marxist, right? And he says, frequently arguments concerning the police and policy start out looking like critique and ending up in apology. So I'll end there. Thank you so much, everyone.